From Diamond Pharmacy Services, this is PodcastRx, a monthly show that takes you behind the counter of the nation's largest correctional pharmacy provider. We bring you conversations with pharmacists, nurses, managers, and other Diamond staff about the topics and issues we see in corrections, long-term care, and community health settings. Our chats aren't limited to purely pharmacy topics, and they aren't strictly clinical either. So if you're a healthcare provider or just enjoy healthcare podcasts, we think you'll enjoy this show. On this episode, optics pharmacist Chris Bender is back for a rundown of some timely COVID-19 clinical topics. We discuss the Novavax vaccine, the anticipated rollout of fall booster shots, the use or underuse of Evusheld, the Paxlovid rebound, and more. Chris also takes a moment to thoroughly go over all the current clinical guidance for booster shots. This is PodcastRx, and I'm Adam Campbell. Chris Bender, always a pleasure to have you back on the show, and this time in person, no less. I don't know, the last several shows that we've recorded, it's been remote, so it's good to see you again.
Yeah, it's nice to be back together again.
Yeah, and here in the offices of optics too, no less.
Yes, hopefully we got the nice echoey chamber of the optics office.
Yeah. It's perfect. The last time that we talked about COVID-19 treatments, it was February of this year, and the big news revolved around the oral therapies Paxlovid and Lagevrio. And for those curious, that was episode 26 of PodcastRx, and I definitely encourage you to listen to Chris's breakdown of those oral antivirals if you haven't already. So now we're into August 2022, and there's a flurry of news about new vaccines, boosters, and other COVID topics. Now, we've lived with COVID for a few years, so that may not be as top of mind for everyone, especially those out in the community. But of course, there's still many noteworthy developments in the clinical arena that one could miss. So Chris, I thought we should have another Roundup discussion to make sense of all these clinical updates and stay up to speed. What do you say?
Absolutely, Adam. Thanks, as always, for inviting me onto the pod.
Of course.
I'm hoping that today can be a real knowledge booster. I'll see myself out.
Well, I appreciate that kind of humor, so we're just going to roll right from that. To start, arguably the biggest development in these COVID topics is the Novavax vaccine. As its name implies, it's a new vaccine in the armamentarium. But unlike the newish mRNA vaccines from Pfizer and Moderna, this vaccine relies on 70-year-old, and I use old in quotes here, technology, 70-year-old technology. And also another thing I want to point out, to be fair and clear, Novavax is the name of the pharmaceutical company, not the actual product name. That would be Nuvaxovid, and Novavax is the actual brand name for the drug. Either way, there's an understandable focus on new here. So Chris, if you could, please give us a rundown on how the Novavax vaccine works, efficacy, how it relates to vaccines already available, and so on.
Sure. So I guess a good place to start is by saying that the Novavax vaccine is actually a recombinant subunit vaccine. And you may recall, if you've listened to our previous episodes, we kind of did a dive into what the different types of vaccines are. Well, as its name implies, this type of vaccine uses purified and inactivated, quote unquote, subunits of particular pathogens, basically in order to induce the body's natural immune response. Now, the term subunit here can be pretty broad, and it can actually take many different forms. So, for example, some subunit vaccines use various proteins from the pathogen, while others use like fragments from bacteria that have outer shells, sort of like a pneumococcal bacterium. In the case of the Novavax COVID-19 vaccine, the subunit that it uses is obviously the infamous spike protein that we know is found on the outside of the SARS-CoV-2 virus. So some things, to highlight, the subunit vaccines have been around for quite some time, as you had alluded to previously. And this is really because of their effectiveness, but also their safety. In fact, the first recombinant protein vaccine was actually officially licensed in 1986, and that was for hepatitis B. So since then, we've also seen this type of vaccine used for pneumococcal, like I said before, as well as meningococcal vaccination. Now, it's important to kind of take a pause here and just note that these subunit vaccines, because they're only containing pieces of pathogens, they're not capable of causing any disease. So just to allay some fears, or any concerns that with that regard.
Right. And I wanted to say on top of that one really interesting facet of this vaccine is that protein is made using moth cells. And the adjuvant, if you remember what adjuvant means from our old podcast discussion on vaccine, that's the material that enhances the immune response. That's made from soap bark tree extract. And, that's all in all, that's an incredibly fascinating piece of bioengineering with this vaccine. But really what that underscores is there's no real piece of SARS-CoV-2 virus in this. This is how it's been engineered to get that immune response.
Exactly. Yeah. It's all basically a way to get the most bang for your buck while causing the lowest risk of giving someone any harm, basically. So they're using a very small piece of pathogen that's functionally incapable of doing anything. Yet, like you said, through the use of an adjuvant, which is amazing, the different types of adjuvants that they can use and the different production methods that we can use nowadays. Hamster ovary cells, moth cells, stuff like that. They're using everything. You're able to induce a robust immune response without giving someone the actual disease. So it's amazing that we've come, this far. Now, so that's obviously the safety piece. But with regard to its overall effectiveness, I just want to highlight the fact that the clinical trials showed a vaccine effectiveness of 90%. Not to go too deep into the weeds of what those numbers represent, but that's basically based on the fact that 0.1% of the vaccinated participants became infected compared to 0.9% of the unvaccinated participants. I just want to do a callback to the mRNA vaccines and highlight the fact that this 90% efficacy is fairly comparable to what we saw with the mRNA vaccines when they first came out. We remember they had effectiveness rates somewhere around the 95% mark in their initial clinical trials. Now, there are some key things to keep in mind, however. So first is that effectiveness was lower in the elderly population. Now, of course, that's a commonality that we see across all vaccines. But it is important to remember that despite this lower effectiveness, the vaccine still remained effective in preventing severe disease in those who did happen to become infected, which is arguably the most important thing that you could expect from any vaccine, obviously. And then second was that the clinical trial was performed in 2021, which was before the Delta and Omicron surges. So some of the things floating around in the medical literature right now is just simply the fact that we don't have any information regarding how well this vaccine will work once it's deployed in the wild against all the new Omicron variants that are coming out, or subtypes. But it's important to remember that even during those Delta and Omicron surges, the mRNA vaccines, the ones that initially worked so well, they lost some effectiveness in preventing infections, but they still, again, protected against severe disease, hospitalization, and death. So while I can't say that that's for sure going to happen with the Novavax vaccine, that's at least, we're hopeful that the same theme would remain true.
Right. And also to clarify that Novavax is only authorized for anyone 18 and older. And it is also like the Pfizer and Moderna vaccines, it's 2-dose primary series, no booster right now. And I know you'll get into that a little bit later, but that's just where we're at with that. What's the overall what's the overall availability like of the Novavax vaccine?
Yeah. So based on what I found was the most recent operational guidance from the CDC. It appears that there are approximately 3 million doses available of the Novavax vaccine, which, as you just said, is a 2-dose primary series. So doing the math, that's enough for 1.5 million individuals, which, if you think about that, that's a fairly limited supply.
Yeah. And what would you say about demand for it? That as far as where the demand is right now, that's a good start.
That's
at least.
Probably a good starting point, because I think, as we'll kind of get into further, I do think this might serve a little bit, a bit of a niche. So possibly that limited supply could be sufficient, at least during the initial phases of rollout.
Well, and when you're talking about demand for it, a good related question is that this vaccine uses I again, in quotes, time-honored technology. So do you think, given that it's been around, this is using technology that's been around in vaccines for a long time, do you think that makes it more attractive for people who are still hesitant to get the vaccine in the first place?
Yeah, obviously, my hope is that that's a resounding yes. Clearly, this is going to provide an alternative option for those who, simply can't receive the mRNA vaccines, either be it through an allergy or they've had an adverse reaction to their first dose in the past. But as you alluded to, hopefully this will also provide an option for those who were hesitant to receive like the mRNA vaccine, because obviously that technology was a bit newer. It had less long-term safety data. So with this vaccine, we have, as you said, the research was started back, 70 years ago. They were approved 36 years ago. So doing that math, we have 36 years of long-term safety data just since they've been FDA approved, this type of vaccine, I should say. So hopefully that long-term safety data will be a bit more reassuring for those who may have some degree of hesitancy.
Yeah, here's hoping. Another big development related to the vaccines is the targeted fall rollout of booster shots against the BA4 and BA5 Omicron subvariants. Specifically, the FDA has asked the major vaccine makers to develop bivalent or two-component boosters that will provide protection against the original strain of COVID and these newest variants, essentially keeping inoculations up to date. However, there are a lot of unknowns here, especially regarding eligibility and when exactly in the fall new boosters will be available. So Chris, what can you tell us about these developments and how do you see the rollout actually playing out?
Yeah, so first, it should be stated that the original vaccines, they do still provide a fairly high level of protection against severe disease across all variants, and that's including Omicron, so long as the individual is up to date and boosted. However, it's been speculated for quite some time now that broader immunity could be achieved by including an Omicron component in a booster dose, for example. So for this reason, we know that Pfizer and Moderna have actually been studying bivalent boosters, which is a combination of two different strains of SARS-CoV-2 that would ultimately include the original SARS-CoV-2 strain and an Omicron strain. The bulk of the clinical data has shown positive results from the boosters. However, the data came largely from boosters that included the Omicron BA1 subvariant, which has been rapidly outpaced or replaced by the BA4 and the BA5 variants in the community, which from much of what I've been reading from experts, this may suggest the fact that BA4 and BA5 came on so robustly and kind of overtook BA1 may suggest that immunity to BA1 may be less robust or it may be fairly short-lived. So basically for that reason, the FDA has been requesting that if any manufacturer is going to roll out any bivalent booster, that they would prefer that the bivalent vaccine include the original strain plus either a BA4 or a BA5. Now, the main drawback to this requested change is that we may not have as much data prior to the rollout of a BA4 or a BA5 booster, because like I said, all of the bulk of the data thus far has been using an original plus a BA1 booster. Fortunately, we've seen and we know that the mRNA vaccines can really be rapidly reformulated, manipulated, and manufactured. So I don't think this change would slow the overall rollout to a significant degree. So that's a really a good thing.
Short of like a brand new variant, whichever Greek alphabet letter is still available, but yeah. But that has always been really at the heart of it. One of the best benefits of the mRNA vaccines is they're like such a modular type of vaccine that can really be plug and play. So while we may not have as much data from a clinical perspective, we know from a manufacturing standpoint that that'll never really be the delay. Now, you had asked or you had mentioned
eligibility. And I think that's going to be probably one of the most interesting things to see here. So, if we learn anything from the initial rollout of the mRNA vaccines, we can probably guess that initial eligibility is probably going to be limited to like the highest risk populations, probably the elderly, the immunocompromised. And from what I can tell, the best estimate is that these boosters may be available around like mid-October, or at least that's the goal.
Sure, and that makes sense because that's right in time for the onset of, what we've always known as cold and flu season. Well, really, It's cold, flu, and COVID season. Yeah. I thought it would be useful, Chris, if we could do a refresh on what the current clinical guidelines are for boosters. I know this is convoluted, and
to put it lightly,
but you'll no doubt break it down well for us. So if you could go through those again, just to provide some clarity.
Yeah, and I want to go through these. I want to be thorough and as succinct as I can. So I hope that I don't lose anyone through this, because obviously, as you had mentioned, as more and more vaccines enter the market for more and more age ranges, we're starting to get recommendations for slightly different age ranges. Some require boosters, some don't require boosters. So probably, to put it lightly, the booster landscape is becoming more and more convoluted at this point. Fortunately, the CDC has done their best to create some helpful charts and some tools that can help inform this conversation. And obviously, those links are going to be provided in the show notes, because these are the reference that I used and stared at long and hard before we had this discussion. So to put it at the most simplest, the CDC recommends COVID-19 boosters for everyone ages 5 years and older. But that's where the simplicity ends, and this is where things get more difficult. So children ages 5 to 11 who received the Pfizer vaccine, note just the Pfizer vaccine, for their primary series should receive one booster at least 5 months after that primary series. So I want to make note that children in this age range who receive the Moderna vaccine for their primary series, they do not require a booster at this time. I would imagine that could change in the future, but at least as of right now, if they received a Pfizer, get a booster. No, if they received a Moderna, no booster. This is basically similar for children and teens ages 12 to 17, who, if they receive the Pfizer vaccine for their primary, they should receive one booster at least 5 months after their primary series. Again, if these individuals 12 to 17 receive Moderna, they do not require a booster at this time. Moving into the adults, so adults ages 18 and older who received either mRNA vaccine, so we're talking Pfizer or Moderna, they should receive one booster at least 5 months after their primary series. Adults ages 50 and older should also receive a second booster at least 4 months after receiving the first booster. We do remember, though, that adults could have received the J&J vaccine as well. Not everyone received the mRNA vaccine. So adults who received the J&J vaccine as their primary series should receive one booster at least 2 months after the series. And again, adults age 50 and older should also receive a second booster at least 4 months after receiving the first booster. What's interesting is that currently boosters are not recommended following primary vaccination with the Novavax vaccine. That may simply be due to the fact that we don't have the long-term follow-up data. So if I had to guess, people will probably still get boosters after a Novavax, but as of right now, people aren't far enough out from their Novavax vaccines to even be considering boosters anyway.
Right.
One key patient population that has been like a focal point throughout this, or like an island unto their own, are immunocompromised patients. So immunocompromised patients, regardless of age, qualify for 2 boosters if they received either the mRNA vaccine or the J&J vaccine. The first booster should be given 3 months after completing their primary series, and the second booster should be given 4 months after the first booster. And just as a reminder, with regard to, I know we're talking about boosters, but immunocompromised patients can actually receive the most doses of all because their primary series is actually 3 doses. If we're talking about just the mRNA vaccines, their primary series is 3 doses, and then you add 1 and 2 boosters to that, they can actually receive 5 total doses as of right now. So I know that's just a ton of stuff, but in an attempt to recap and clarify a little bit, to kind of recap and simplify a little bit, the youngest and the newest authorized group, those ages 6 months to 4 years, do not yet need any boosters. Children and teens aged 5 to 17 should receive 1 booster if they received Pfizer for their primary series. Adults 18 to 49 should receive 1 booster. And finally, adults 50 years and older and immunocompromised individuals of all ages should receive 2 boosters. And again, individuals who are receiving Novavax as their primary series are not yet authorized to receive any boosters.
Remember the Diamond Drug Information Center? That group of expert pharmacists who help Diamond customers with their medication questions? Well, I'm here to tell you that they're a thing of the past, but not in a bad way. No. The Drug Info Center has a new name and a new mission. We're proud to introduce the Office of Pharmacy Therapeutics and Integrated Clinical Services, or OPTICS. Instead of offering just drug information, the pharmacists of OPTICS are moving their services closer to direct patient care. Whether it's through collaborative formulary management, medication therapy management, or individual patient care plans, the OPTICS team is ready to integrate their clinical pharmacy expertise into the day-to-day operations of medical teams in corrections and long-term care, and they'll continue to offer the same drug information resources they've provided in the past. To get a clearer view of OPTICS and its mission, go to diamondpharmacy.com/OPTICS team to learn more. Now back to PodcastRx.
So moving away from vaccines and boosters, one COVID treatment that we've not covered on this show is Evusheld. It's an investigational monoclonal antibody medicine that provides pre-exposure prophylaxis to prevent against COVID-19 in severely immunocompromised patients for whom vaccines may not work, or those who are unable to receive COVID-19 vaccines due to a history of a severe adverse reaction. It was granted EUA status in December of 2021, right around the same time that Paxlovid and those oral antivirals were. So because we haven't covered it, Chris, can you go more in depth on the efficacy and availability, what we know about Evusheld?
Yeah. So the major, to bring it back, to a little bit of data. So the major clinical trial that evaluated Evusheld showed that symptomatic COVID-19 infections occurred in 0.3% and 1.8% of patients receiving Evusheld and placebo, respectively. So what this means is that patients who received Evusheld had an 83% lower risk of developing symptomatic COVID compared to those who only received placebo. So I want to just note right here that is a pretty high effectiveness rate. And if you remember the 90-95% effectiveness of the vaccines, that's obviously getting close to the effectiveness that we see with the vaccines. Yeah. Now, with regard to availability, at the time of our recording, they're just shy of 200,000 doses of Evusheld available in the U.S. Now, I want you to compare that to the availability of treatments, like you said, Paxlovid and Lagevrio, which number near 1.5 million courses for each of those. And comparing those two, you can kind of see that there appears to be a production emphasis on treatments over this preventative approach.
Related to that, one article that I came across during research for this episode, published on WebMD no less, it discussed how underutilized Evusheld is, that many providers and patients, they're unaware of it. Several reasons were cited for this in that article. Initially low supply, not enough community health centers ordering it, just a general lack of communication. And given that you work with providers in correctional facilities in the institutional space, how has the awareness looked from where you're sitting?
Yeah, unfortunately, I would consider institutional awareness to be low, just like we're seeing in the community. So they're really no different. But I don't think this is necessarily intentional in most cases.
Sure.
Now, as you alluded to in the question, there really are a myriad of explanations or a myriad of possible explanations for this. Obviously, the first issue that I see or that I've seen has been really education and promotion. Obviously, here you could lay some blame at the feet of public health agencies, but you really also need to understand that generally speaking, a lot of public awareness is driven in the media from the drug manufacturers themselves. And unfortunately, during medications that are given emergency use authorization are actually fairly limited in the amount of marketing that they're allowed to do. So that probably plays a large role because you're not seeing as much manufacturer awareness campaigns as you do with all of the diabetes drugs that you see on TV or shingles vaccines that you see kind of plastered all over television advertising. Now, another thing to consider, and this is something that you alluded to as well, is the timing of when Evusheld was authorized. That was December 2021. And do our listeners remember what else was authorized at the exact time? Right. Paxlovid and Lagevrio. So if anyone remembers around that time, they can remember the amount of, just like the sheer amount of media buzz that they were receiving at the time. So given all of the buzz for that, just the oxygen was sucked out of the room. And it's easy to understand how Evusheld may just have simply been forgotten about from a media perspective. Some other things to consider too is that for those providers who actually were aware of Evusheld when it first came out, they'll tell you that, they'll be able to tell you that the initial rollout was fairly small, with limited access and restricted availability to the product. So, as time goes on, they may no longer think of Evusheld as a readily available option for the patient, or because they haven't gotten a chance to utilize the product so much, they may simply be hesitant to use it given their limited clinical experience with the medication. And it's unfortunate, but there is also this perceived lack of necessity among providers or patients. It's easy to say it's not worth going through the effort to obtain that Evusheld injection since we have such effective treatment options now. But I always kind of distill it back down to, Benjamin Franklin once said, an ounce of prevention is worth a pound of cure. So, for many, the use of this preventative product can provide immense benefit.
You did say at the top that institutional awareness was low in your view of Evusheld, but have you had any partners from the facilities that Optics works with contacting you about it, wanting to learn more? Have you had any interest in that?
I've spoken with a few providers about it, mostly just from an educational perspective. I actually don't think that we've seen a lot of it actually be dispensed to our facilities. So for one reason or another, there are many facilities, many providers. So me having a few conversations, unfortunately, is just a drop in the bucket compared to how many people actually would need to have those conversations in order to spread that awareness. So no, unfortunately, I haven't had much contact or involvement in the institutional setting.
I understand that there's some other clinical considerations for Evusheld at the moment. Can you outline those for us?
Yeah, so probably the biggest news regarding Evusheld recently has been the dose increase. So Evusheld was first authorized to be given as two separate intramuscular injections of the two medications, tixagevimab and sogavimab, basically 150 milligrams of each. However, recent evidence has shown that this dose of 150 and 150 had reduced potency against the first Omicron variant. So basically, in order to compensate for this, the dose has been increased to 300 milligrams of each component. And this has actually shown sustained effectiveness against Omicron variants. So that's a promising thing. And it's also now recommended to be given every 6 months in patients who need it in order to maintain continued effectiveness. That's an update because when it was originally authorized, it simply was authorized for one injection, but it mostly was due to the fact that nobody knew when the next injection would be needed, and they figured they'd cross that bridge when the time comes, which it's now every 6 months. Another small update is that the original batches of Evusheld were dated with an 18-month expiration date. The FDA has expanded that now to 24 months. And really the only reason this is significant is that just means that current supplies will stay viable for longer. So hopefully we'll be able to stretch the supply lines a little bit.
I wanted to move on to the final topic of today's Roundup, and that involves Paxlovid. And as I noted at the top of the show, we had an in-depth discussion with you about it in episode 26. But one area that wasn't on our radar then and is now a topic of concern for providers and, of course, patients is what's known as the Paxlovid rebound, wherein a patient will show a rebound of COVID symptoms within 2 to 8 days of completing a 5-day course of the drug, sometimes even testing positive again. Most famously, President Biden experienced this somewhat recently. Statistically, Chris, how likely is this rebound, and does this throw the efficacy of Paxlovid into any sort of question? And have you been getting questions on this from your providers?
Yeah, so while the concept has certainly garnered a lot of media hype, I just want to, allay any concerns by stating that the actual incidence of rebound is fairly low. So I found a recent study that looked at data from over 13,000 patients, and at 7 days after finishing their Paxlovid course, 3.5% tested positive, 2.3% had symptoms, and 0.44% were hospitalized. So you can see that the more severe things are very, very rare. Just testing positive in general is fairly rare afterward. So obviously while this is rare, this has led to a growing area of research because obviously the medical community is concerned about the possibility of antiviral resistance, or in other words, are our treatments losing their effectiveness against COVID-19? And fortunately, there's been some recent research on this that basically ruled out the possibility of resistance as the cause of Paxlovid rebound. Now, the research ultimately suggests that insufficient drug exposure is the most likely cause. And to me, this makes some sense. So if you'll remember during our discussion about Paxlovid, Paxlovid is the combination of 2 drugs, and one of those drugs has the sole responsibility of just boosting the level of the other drug in order for that main drug, nirmatrelvir, to be fully effective. Well, if you think about it kind of logically, if nirmatrelvir needs to be boosted or increased by another medication just to be effective, then any circumstances that lead to lower or slightly lower nirmatrelvir levels might impact Paxlovid's overall effectiveness. This could be the result of potential drug interactions, or in some cases, we all fluctuate with regard to kidney function. Some people may just be clearing the medication a little bit quicker or a little bit better than others. Now, despite this being rare, obviously the media hype is real, so we have been getting questions about this from our providers. Fortunately, the CDC has some really clear guidance on this issue. So in the event of rebound, the patients should re-isolate for at least 5 days. They also want to be, free and clear of fever for at least 24 hours as well before they, come out of isolation. And a mask should be worn for 10 days after the onset of symptoms. There's been a lot of questions regarding, do I give them another course of treatment or anything like that? And currently, retreatment is not recommended at this time.
I think just as a general statement, it's useful to consider that with any new treatment like Paxlovid, you're going to have fits and starts of progress, and you're going to have to refine things along the way. And overall, you still have a treatment that works, ultimately.
Yeah. So. And I think the important takeaway from this overall is that the rebound, if it does occur, does not appear to be clinically serious.
Yeah.
And so it's mostly just, at the most, it might be an inconvenience, if you were to have to re-isolate, which is a fortunate thing.
Yeah. In other clinical news, Paxlovid was also given extended shelf life guidelines similar to what we just talked about with Evusheld. Can you talk us through the significance of this?
Yeah. So, this news obviously doesn't impact individuals outside of the clinic. setting, but it is good news for clinicians and the overall product supply line as a whole. Basically, as we'd mentioned with Evusheld, basically when Paxlovid was originally granted EUA in December 2021, all of that available product was given a 9-month expiration date. Now, since that time, newer product has been manufactured with a 12-month expiration date. So basically, the FDA has granted an additional 3 months of shelf life to those original boxes of Paxlovid, which, as I said, for Evusheld means that hopefully, fewer doses of Paxlovid will need to be wasted, and that we can better utilize our current therapeutic supplies.
One piece of our discussion from February that stuck out to me were the logistical issues that limited the supply of Paxlovid to institutions like nursing homes and correctional facilities. And I'm going to assume that this situation has improved considerably, if not drastically, since then.
Oh, yeah. If you'll recall from our previous discussion, basically institutions were being directed to the health department to obtain, any of these medications. Fortunately, now Diamond is able to provide these medications to patients in both correctional and nursing home settings. So ultimately, I'm hoping, this will simplify the process for our facilities, but also improve access to these medications as time goes on.
Well, certainly more simplicity is always welcome, especially in matters like these. And of course, Chris, we're always grateful that you could come on PodcastRx and simplify clinical topics for our understanding. So Chris Bender, for the millionth time, thank you again for joining us.
Well, thank you, Adam. Always a pleasure to be here, and I look forward to our next discussion.
Well, that'll be sooner rather than later, I can assure you.
Sounds good.
All right, thanks.
Take care.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.